Thank you for the lovely introduction and how wonderful it is to be here in person. I've been really enjoying this past 12 months when we're starting to go to conferences in person and shifting off the Zoom. Not that there's anything wrong with Zoom, but it makes a difference when we're all in the same space. And I think particularly for a topic like this, where we're talking about practice change, because it's sticky. There are sticky problems, and I think it lends itself well when we're all in the same room and we're trying to generate solutions, and we're talking about it together as a team. Before I go into the content, I wanted to talk a little bit more about myself, well, not too much, just a little bit more about how I came to be specialising in implementation science. So first of all, I'm a health professional. I'm an occupational therapist by background. I have been for many years, and I continue to be, so I'm still registered and I still do some clinical work at a major hospital in Melbourne. My area of expertise is in the neurosciences, and I've worked across the spectrum. Acute settings, rehab settings, community settings. I've worked for the local government, and I've also worked for different organisations such as disability-specific organisations. My research is on two quite distinct areas, but they do overlap. So the first area that I do research in is around design and development of biomedical innovations. A very strange area to be in, but kind of exciting. So I work with consumers and engineers and clinicians, and we develop robotic devices for neurorehabilitation. Now, the second area that I'm interested in, which kind of relates to the first area, but it's also what we hear about today, is methods to identify and address the gap between the production of evidence and its routine use in everyday clinical practice. And I want to tell you a little story. Actually, today, through my presentation, I'm going to pepper it with my own stories from clinical practice and research. So the reason I became interested in this topic of this gap between evidence and its implementation into practice, I was starting a new job at a major hospital, and I was appointed as a senior clinician. So I arrived, bright-eyed and bushy-tailed, and I was pretty keen to do a good job. And I saw my first patient. It's a patient who was recovering from a stroke. And they met all the eligibility criteria for a specific treatment. Now, this treatment has a really strong evidence base. It's in the guidelines, and it's what you should be doing, provided the patient meets the eligibility guidelines, which this person did. So I went back to the department, and I was looking for the particular device. It was a neurostim device. And I was looking around desperately through the cupboards, like, where is it? And I couldn't find it. And I said to a few other clinicians, where are your stim devices? And they said, oh, we don't have any. And I said, what do you mean you don't have any? And they said, well, we don't do that here. And I said, well, how can you not do that here? Major service, pretty much setting the standard for Australia in terms of this particular clinical population. And there wasn't really a good reason for why they weren't doing it. It wasn't that we couldn't afford the equipment. It was really low-cost equipment. It's like $100 for a neurostim machine. But what that told me was that knowledge and skills aren't really enough to be able to deliver evidence-based practice. So there I was, I knew what I had to do. I'd done it hundreds of times before at other health services. The evidence base was really strong for it, but there was something else that was going on that was preventing me from being able to implement that into practice. And that started for me this kind of lifelong, I'm going to say obsession, around implementation science. So how do we work out what's going on to prevent us from being able to deliver the sort of care that we want to deliver and that our patients deserve? So that's how I came to be an implementation science specialist. And it's not a solo sport, ever. I work with lots of different people, so that's my implementation science team there, and they're nurses, psychologists, physios, medical clinicians. There's a whole range of different people there. Of course, I work with the organisations Kylie mentioned earlier on. I work with grassroots organisations. I've got a project I'm doing with Brain Injury Matters at the moment, and at the heart of it all, I work with consumers a lot. Because of course they're central to all the work that we do. They're the ones that we want to be able to deliver the best care to. So today what we'll look at is care gaps, and I don't want to spend a lot of time on this because I feel like we all know it. We all know that there's gaps in what we do or what the patients are receiving, but I will touch on the types of care gaps that are happening out there and what the cost is, not just to the patient, but generally in terms of the economy. Some methods and theories and frameworks. There's so many of those. We're not going to go through all of them, but I want to reassure you that it can be a little bit confusing when you're faced with choosing one method or framework out of, I think it was 65 at last count. So I'll talk through some of the methods and frameworks that I use, with the intent being you don't have to follow mine, but showing you why I select certain methods and frameworks and how I select them. And then I'm going to really do a deep dive into de-implementation of low-value care. So that's become a little bit of the popular kid in the last 5 to 10 years. So we'll go through what that means, low-value care, and what de-implementation means. And I'll give you some specific examples of how we might be able to do that in our clinical work. So let's get started. Care gaps. They're common, unfortunately, not just in Australia, but certainly internationally as well. This is a study that was done in Australia by Runkman and colleagues more than 10 years ago, and it's a really interesting study about care gaps. What they did was they interviewed 1,000 consumers who had recently had a healthcare episode, and they were looking specifically at 22 health conditions. And in these telephone interviews, they were looking for the proportion of patients who had actually received care that was in line with the evidence, whether that was actually RCTs or if they had received care that was in line with consensus guidelines. And what they found was that in 57% of those situations, they had received appropriate care, but in 43% they hadn't. Now that varied depending on what the condition was. So I've just popped that up there so you can see that for some conditions there was a very high compliance with the evidence and with consensus guidelines for things like coronary artery disease. And as you go down the list, you can certainly see that compliance reduces somewhat, and that we've got some areas that are almost intractable. And I'm sure that this won't surprise anybody here. So things like antibiotic use. So we continue to prescribe antibiotics in situations where it's not warranted. Again, this is Australia, but this happens globally. Another area that we continue to experience problems with, where the treatment or the interventions aren't matching the evidence, is around lower back pain. I'm particularly interested in that because it seems that we know the evidence says that analgesia and education is what's suggested, and yet we continue to prescribe imaging, which is costly and unnecessary in most situations. So this tells us that we've got some areas of greatness where we're doing really well, and some areas that continue to be quite challenging for us. From a global perspective, the stats that I just gave you then, around 57% receiving appropriate care, that's reflected really across all first world nations. Generally, 60% of the time, the care is good. 30% of the time, care is low value. And by low value, I mean either it has little to no evidence or there's premature implementation, and I'm going to go into a lot more detail around that. And in 10% of situations, we're delivering care that's actually harmful. So that's Australia and across the world. And of course, there's a cost. We'd be aware of what the cost is to our patients. Obviously we want to be delivering the right care to them at the right time. But there's also a cost in terms of finances and economy. So what we know from this study by Schrank and colleagues, and that was done a few years ago, they looked at two levels, or they grouped gaps in healthcare in two different categories. The first one being failure of care delivery, and the second one being over-treatment or low-value care. And they are able to determine that the failure of care delivery costs roughly 4% of the total healthcare budget. And I think it's somewhere between $160 billion a year, thereabouts. And the second cost of a care gap, which is around over-treatment, costs $70 to $100 billion. So that's every year. Now, we haven't done a similar study in Australia, but what I did was I extrapolated those figures and I applied them to our health budget. And if we do that, we know that our healthcare budget is just shy of $106 billion each year. And if 4% of that budget is on failure of care delivery, that costs $4 billion each year. And 2.6% of that would cost $2.8 billion if we're over-treating or for the delivery of low-value care. And that's actually in line with what we are seeing with some of the AIHW and safety reports around adverse events and low care. So that's not a surprise to me. So when we talk about care gaps, there's at least 5 that have been identified in the literature. I'm sure that there are more, but this is just really what's the latest in what's published on the topic. So the first one is around slow uptake of new interventions. And that's probably the one that we're most familiar with. That's where there's strong evidence for the treatment, but there's a really big gap between getting the evidence and implementing it into practice. And I'm sure everybody in this room is familiar with that statistic that it takes roughly 17 years, or the median is 17 years, to get evidence from being found to be effective to the bedside of the patient. Which is a really long time and it has implications, particularly for certain diagnostic groups, such as oncology or in cancer care. An example from my field around slow uptake of new interventions or failing to deliver high care is in stroke. So in the most recent National Stroke Foundation audit, that's in the acute audit, we found that nearly a quarter of patients don't receive risk reduction education. And that's really important. If a quarter of patients aren't receiving that, they are more likely to experience another stroke, because we know that about 80% of strokes can actually be prevented through reducing these risk factors. And that of course has a cost, and we discussed cost before. The second care gap is around premature uptake of interventions or delivering low-value care. So there's 2 ways that premature or delivering low-value care occurs: through implementing or taking up an intervention where there isn't a strong evidence base. And I'm going to talk about an example in a moment from a healthcare setting, and I think it'll probably resonate to some of us here. And it's also about continuing to deliver interventions that have low or no evidence or might be harmful. So both of those are captured under that title of a care gap. So my experience of premature interventions, I was working at a healthcare service, and we had a problem with our rates of asking patients, do you identify as Aboriginal or Torres Strait Islander? I think we have that problem across all of Australia, not just at the health service where I work. And what had happened was that an intervention had been developed and it had been implemented. And that intervention was to deliver a series of workshops around how to ask this question. And the reason I was called in for this problem was that after they delivered this series of workshops, the problem got worse. So the rates were even lower still, and they continued to plummet. So my boss at the time said to me, what's going on? This is meant to fix the problem. We were meant to be better at asking the question, and in fact, we've become worse at asking the question. And I started off by going to the people who were central to this issue. So I went to ward clerks, NUMs, the clinicians, anyone who was doing admissions, to actually say to them, what's hard about this? Tell me in your own experience what the problem is here. Because nobody had actually done that in the first instance. What we'd done, and I'm going to borrow this phrase from one of my colleagues, what we had done is we had developed an elegant solution, but to the wrong problem. And we do that a little bit in health services because we're reactive. And I say we because I still work for a major health service. And we're fast and we want to get things done, and we don't want to spend a lot of time in that space of trying to work out and pinpoint what the actual problem is. And just to let you know, the problem was not that they didn't know how to do it. or not that they didn't value doing it. They all thought it was tremendously important, but they were worried about people getting upset and offended at being asked and how they would manage that scenario. Some had had an experience where there had been an agitated response. So they didn't feel that they had the skill set to be able to manage that situation. None of that was covered off in the workshops. And it could have been, right? So if we had have spent that little bit of time to go, well, what is the problem? Those workshops could have had some practice of what do we do in the scenario where somebody gets really mad because you've asked them that question. And we might have had some different outcomes, and those rates of asking the question might have actually improved. So that's an example of, I've put this Lagiat principle up there, which really makes me laugh because I'm guilty of it too. We develop interventions because it seems like a good idea at the time. But in fact, we haven't really hit the problem properly. And understanding and identifying the problem is really important. And I'll go through some methods to do that. The next type of care gap is keeping up with emerging evidence. Gosh, it's hard. Things are changing and often quite rapidly. And I think, both Craig, you talked about that and the importance about being able to access evidence in a timely way and then apply it into practice. I was thinking about a recent example of what's changed and how difficult that's been for people to get it into practice. And I was thinking about pap smears swapping from every 3 years to every 5 years, and how complex it's been for that emerging evidence to actually consistently reach practice. And when I looked it up, I actually found that there were quite a few health professionals who weren't comfortable with saying to their female or their appropriate patients that, oh no, it's only every 5 years now, because they didn't understand the emerging evidence. And the way they were sourcing that information was problematic. And that was addressed eventually. But we certainly had this sticky period of time where we had a group of healthcare professionals who weren't able to keep up with the emerging evidence. Then we've got keeping up with changes in ethos of care. And that's things like when we've got broad sort of changes around, probably my best example is providing patient-centred or client-centred care. That was introduced such a long time ago, but it's about keeping up with general principles of care. And the final one is unwarranted variation in care. And I want to point out that variation in care is important. If we are going to be patient-centred and meet the needs and preferences of our consumers, then there's inevitably going to be variation because they've got a certain condition and they've got values and preferences. So you have to present something or implement something that's appropriate for that patient. But unwarranted variation is when it's not to do with the needs and preferences of our patients, when it's in fact to do with structures and processes, things going on at the organisation level or with the patient. And probably the best example would be that our First Nations people, our Aboriginal and Torres Strait Islander people, have the highest rates of certain diagnoses, but the lowest rates of participating in investigations. And this is that's a complex topic. I'm sure it's not just unwarranted variation in care. There's a lot of things going on there. But it's an example of how unwarranted variation in care is often a major contributor to that growing gap of inequity, because it's often about more vulnerable groups. Good news, can we reduce care gaps? I wouldn't have a job if we couldn't reduce care gaps, and that's probably a few of us here as well wouldn't have a job if we weren't working towards how to reduce care gaps. So we're going to touch on some theories and models and frameworks. As I said before, I'll talk about the ones that I have experience with. First thing to think about is, as it says up here, it's not going to happen overnight. I wish it would. My experience is, in that first example where I gave you, where I arrived at work and I wasn't able to deliver a treatment, it took me 2 years to be able to get that treatment as routine practice, and it was a wild journey. There were all sorts of crazy things that had to happen, and it was a multifaceted approach, but I was able to do it with a team. But I guess it's just important to recognise that it does take some time. It doesn't always take 2 years. It can be a lot quicker than that, but it won't happen overnight. I wish it would, but it won't. Just quickly, theories are generally about relationships between variables, how variables influence each other. And frameworks are really more about the how-to how do we go about doing these things? What are the steps to being able to change practice? I'm sorry, that's probably a very simple version, and I'm sorry for any theorists that are out there because I've very much simplified it, but I think it's easier to sort of start with those simple definitions. So where do we start if we're thinking about that there's a problem with practice and we want to work out how to address it? Simon French and colleagues developed this 4-step process, which I love. And I pretty much always start with this. So I've been a health services researcher for a really long time, and this is always my go-to. And this is what I use with my research partners as well, because it resonates with us clinicians. We can look at this and go, all right, I can work with this. It's not getting overly complex. So the first thing that we need to ask is who needs to do what differently? And I'm going to go through an example of how I've used these steps for a problem around oral health care. When we're talking about who needs to do what differently, the what is the behaviour. So just briefly, I've put up a definition of behaviour, just so that we're all clear around what we mean when we're talking about behaviour and behaviour change. So behaviour is anything that a person might do in response to a stimulus. That stimulus might be internal, what we're thinking about, or external. And it could be overt and measurable. So it could be something that we can see and easily measure. Or it might be covert, something that we don't easily see and require an indirect measurement. So that's the accepted definition of what a behaviour is. Behaviour change techniques, we're going to talk a little bit about that today, and I think we'll probably talk about that later on in the workshops as well. It's one of my favourite topics. Behaviour change techniques are strategies that you can see. They've got to be observable. And they've got to be able to be replicated. And that's really important because it's a science, right? So you've got to, if you can't replicate it, then we can't really attribute the change in behaviour to that strategy. So Simon French's 4 steps. We've got to work out, first of all, well, who are the actors in this situation? And what are they doing? And what do they need to do differently? What barriers and enablers are influencing their behaviour? And how are we going to identify that? What framework are we going to identify that's going to help us target those barriers and enablers? What behaviour change techniques can we use to reduce or address modifiable behaviours? It's important to note modifiable behaviours. Some stuff can't be changed, so we're interested in things that can be. And often that's enough to be successful and get practice change. And the final step being evaluating why it was effective. So I'll talk you through how I did this process with a recent problem that we had in a hospital, and it was around the delivery of oral health care with hospitalised survivors of stroke. We know that that's a problem. We've known that for some time, again, from the national stroke audits, and we actually knew at the hospital as well that it was a problem, and it was a topic that the hospital was interested in exploring a little bit more about. First of all, who needs to do what differently? And it sort of seems a bit simplistic when I say who, because you can make some assumptions here. When you think, well, who's involved in the delivery of oral health care? My automatic thought is nurses, right? Because the nurses are the ones that are supporting the patients with their morning routines, their bathing and whatever else. So the first thing I needed to do was work out who and also the what. So what is oral health care? I asked the nurses first up when they approached me about this problem. I said, well, what even is it? What do you mean by oral health care? Is it just cleaning teeth? What else is it? And what should best practice look like? So the way I worked out who should be involved in the behaviour, what the behaviour should be, was I went and looked for clinical guidelines. And I found 3 clinical guidelines and 1 hospital policy. And what I actually found was that the people involved was everyone. So it wasn't just nurses, it was speechies as well. Kind of makes sense because speechies are looking at swallow and they're doing a lot of oral assessments. There's also dietitians who are interested in malnourishment and dentition and how people are consuming their foods. There's also the physios, particularly in a stroke unit if there's a trachea. So the physios were also looking at what was happening from an oral health perspective. And maybe it was the OTs too, because the OTs are interested in retraining ADLs and supporting activities of daily living. So it was much more complex than what we first thought about the nurses. And the what is the behaviour? that too was really complex because there are some best practice guidelines out there that tell us what to do. And the National Stroke Foundation really detail that we should be delivering oral health care every day with patients. Didn't really tell us exactly what to do. Also it did say that everyone should be trained, but not really what they should be trained in, or what equipment to use, or what to do with more complex patients. And I'll get to a little bit more information on that. And I also needed to work out, were we doing it right at our health service? So I did a medical record audit, which is a pretty standard thing for most of us. So, I wanted to look at practice and see what was going on there. How far or close were we from delivering good oral health care with patients? And what I found was that, probably not dissimilar to the other stats that I was giving, that in 50% of the time we weren't doing anything with oral health care, or at least it wasn't being documented. To be fair, maybe we were doing it, but we weren't documenting it, but we can only go by what's written in the evidence. And we can see that it's nurses primarily who were delivering the interventions in the acute setting, but in the subacute setting it was the OTs who were primarily delivering the interventions. So I knew that we had a problem with practice. I didn't know yet what the problem was, but I knew that we weren't delivering oral health care as we should be. So identifying barriers and enablers. What I used was a theoretical domains framework, really popular framework. I love it because it's easy to use, and I'm one of these researchers who's a bit lean. Don't have a lot of time when I'm in the health service. If I'm trying to figure out what's going on, I try to use something that can really get to the root of the problem reasonably efficiently. So I had some focus group discussions with a multidisciplinary team. And I did that intentionally rather than semi-structured interviews because the multidisciplinary team worked together. And I knew that interaction, that focus group discussion would unpack more of the problems than individual interviews would. And what I found out was that everyone believed that oral health care was important. And this is interesting. They had really good knowledge about it, so they knew that it was important. They knew that there was an association between poor oral health care and aspiration pneumonia that would blow out length of stay. So the level of knowledge and attitude towards it was actually really high. And the reason I say that was important was that up till that time, literature and studies had only ever focused on knowledge. They kept banging on about nurses need to know more about oral health. Nurses knew heaps about oral health. That was not our problem. That was actually their strength. That was an enabler. The whole team had high knowledge. But the problem was around skills and training, because knowledge is different to skills and training. You can know everything, but when you're there and you have to do it, it's a different kettle of fish. So what we had was high knowledge, not feeling confident about looking into the mouth and what to do, particularly when you're working with more complex patients. So, we had staff saying, or in that focus group discussion saying, well, I know I should be doing it, but they're agitated. And I've got a patient who's a little bit delirious and they're hitting out, I don't know what to do. I've got a patient who's nil by mouth. What should I be doing there? So we were able to actually really unpack what was going on in this situation. And also that it needs resources. So, and that's that bugbear, isn't it, in all health services, is that do we have the resources to be able to do it? So couldn't get to a toothbrush, pretty basic. Probably a really cheap fix too. Couldn't get to a toothbrush. More importantly, maybe couldn't access non-suction toothbrushes or suction toothbrushes. So this really informed what I needed to do next in terms of interventions and delivery of behaviour change techniques. I'm really sorry about this busy slide there. I have put in there a fantastic link to a behaviour change website, which I would encourage anybody who's interested in the field to have a look at it. This behaviour change website actually tells you the techniques that have evidence behind them depending on what your barrier is. So in that situation that I just described, where we had high knowledge but low skills or low beliefs in capabilities, the evidence would actually suggest, whilst knowledge is important, and I'm not going to say don't do an education module, who doesn't love an education module, they're always good, and it's a good starting point, it would actually say that the evidence suggests that behavioural rehearsal is much more important, and that's going to get your practice change. So the intervention can't just be about the education module, it needs to be about watching or working with somebody and doing something together. And gosh, that resonates, doesn't it? And it certainly resonated with the staff that I was working with on this project. And that's the sort of training that they were keen on and the sort of training that they needed. So the behaviour change techniques really need to be selected according to your problem, according to the barriers. And so you need to spend some time. It doesn't have to be a heap of time, but enough time to be able to identify correctly what those barriers are and what the enablers are. So in our situation, enabler, knowledge, barrier, skills and belief in capabilities. And of course evaluating the effects, going through and seeing what's changed, medical record audit, what's changed, and also surveying the clinicians and determining from them what's changed. I'm going to do a bit more of a deep dive into de-implementing low value care. I described and defined low value care before, and I just want to touch on why de-implementation has become a little bit more popular in the last 10 years or so. Most of you, I'm sure everybody in this room has heard of the Choose Wisely campaign, which is about focusing on reducing low value healthcare. And the reason we want to reduce or remove entirely low value healthcare is because it's expensive, and I gave those figures earlier on. It contributes to carbon emissions, it doesn't deliver outcomes for patients, and it costs us resources and time and length of stay. So it all makes sense. We want to get rid of the low value care. And as you can see, I just quickly had a look in PubMed because I was interested in, how many studies have there been around de-implementation recently? And we can see that it's really on the uprise. In the last 10 years, we've really increasingly been focusing not just on addressing getting evidence into practice, but on addressing getting wrong practice out of practice as well. So there are a number of approaches to de-implementation. And they're quite similar to implementation. There are some differences, and I'll go through that in a moment. But essentially, there can be a bottom-up approach or a top-down approach. Bottom-up is when we go to the ground floor staff, to our clinicians, and we look at their barriers and enablers, very similar to the study I described before. We look at the context, we look at the environment, and we see how we can fix that and how we can put into place strategies to address that. Top-down are around policies and guidelines, so it's really about drivers that might be national or local, but driving down and informing practice. We've got a lot of evidence, empirical evidence around the success of bottom-up. We've got mixed evidence around top-down. We've got some really nice growing evidence about the two together. And that really makes sense, doesn't it? You want to have the policies and guidelines, but you also want to have support from your staff around how to do it and be able to address their perceptions of what's affecting practice. There's quite a few frameworks going around to support de-implementation. You might be familiar with the one on the left there, that's the Choosing Wisely framework, and it's an addition or it's an expansion of Simon French's 4 steps. So Jeremy Grimshaw, who's pretty much, I think I'd say he's the grandfather of implementation science, or father, maybe you wouldn't like the word grandfather. He developed that, so he's really driven that sort of approach. And the only difference there to the other 4 steps that I described before from Simon French's 4 steps is this initial phase where you work together to identify what your priorities are going to be for low value care. We can't fix everything in one go. So you have to have this process around, what will we focus on initially? Where are our resources and our attentions going to go? And also the addition of that final phase, which is around scale. If we've worked out a successful way to do this, we should be sharing it. That's really important. We should be able to successfully scale to other settings. So that's been, I think there's a study going on in Canada at the moment using these steps and validating this process. The other framework, it might be one that some of us have seen in this room, it's the Knowledge to Action framework, and it's just been expanded to be used in a de-implementation setting. And it's really similar to the one that Jeremy Grimshaw has developed. So again, identifying and prioritising low-value clinical practices, and then going through the process of trying to figure out why, putting into place the implementation strategies, evaluating, and then looking at whether we can scale. And that's great. I think that's really wonderful to have the frameworks. But I'm always one of those people that goes, yeah, but how do I do it? That's really good, but I actually want to know what the first step is. I love a good framework, but I actually really like that systematic process of what do I need to do as a clinician or a nurse unit manager or a health services manager to put that stuff into practice. So strategies for de-implementation. There's been quite a bit of work looking at what we're doing. Andrea Patey and colleagues did a review of, I think it was about 180 studies, and that review that they conducted looked at whether these studies were implementation studies or de-implementation, and what sort of behaviour change techniques they used, and if there was a difference. Do we do different behaviour change if we're trying to de-implement versus implementation? And there was a difference. What they found for implementation, where we're trying to get good evidence into practice, was that the technique most commonly used is audit and feedback. And I'm not surprised, because that has a strong evidence base, probably one of the strongest evidence bases in implementation science. But what we tend to use more often for de-implementation is behaviour substitution, which is super interesting. And they found that with behaviour substitution, even though that was being used much more often in de-implementation, there was no guidelines around how to do it. How do you select behaviour substitution? So behaviour substitution is where we bring in a new behaviour, ideally a behaviour that has a stronger evidence base, gets better outcomes, and replace the undesirable behaviour. So in their review, they left it off with saying we need to actually have a method. We need to have a process for how to actually do the behaviour substitution. So I'm going to go through and describe the principles of behaviour substitution, but I want to tell you about another one of my recent experiences. I was a health consumer, I mean, all of us are health consumers, quite recently, and I had a little bit of surgery. And as I was being taken into the room to change into my gown, the lovely nurse gave me a pair of non-slip socks. And she said, "Here you go, put these on." And I said, because I'm one of those annoying patients, I said to her, "Oh, there's no evidence. There's no evidence for those non-slip socks." And I could even hear that I was being annoying, but I thought I'll just say it to her anyway. You know, there's no evidence for non-slip socks. And she said to me, she was so lovely, and she said, "Oh, but what will I do? What will I do instead?" And I thought to myself, "Oh, I'm just going to shut up." I said, "Oh, just give me the socks. I'll put the socks on. That's fine," because it was not a big deal, and my balance is fine. But what it did was it made me think about behaviour substitution for a start, and made me think about health professionals. We don't sit well in the space of not doing anything. It's not how we're trained. We're action oriented, right? We're trained to do something. We want to deliver care. So behaviour substitution in a setting where we want to de-implement, like the socks, the non-slip socks, we can't just say to nurses, "Don't do it," or to whoever else is giving out the socks, without saying, is there something else that we can do? So this is where behaviour substitution is really important, because from a practice perspective, as an OT, and I'm sure as nurses or whoever else is in this room, we do better if we're doing something with our patients. That's not to say that there isn't a place for monitoring, and at times we may need to do that, because there may not be a substitute behaviour that has stronger evidence. But it really made me think a lot about behaviour substitution. What we do know is that there are some key principles that might be able to help us with behaviour substitution. And again, Andrea Patey and colleagues have done a nice body of work, and Jeremy and Jill as well, around how we can actually go about doing this behaviour substitution stuff. And I really like these 6 principles because they make sense as a health professional, they're not complicated, and they're pragmatic, because in health we have to be pragmatic. Okay, so principle 1, is there a better behaviour? That's a really good question, because sometimes there isn't a better behaviour. Sometimes there is. So if we think about the sock situation, the non-slip sock situation, what we know from more recent research is that shoes are better, much better than the socks, because the socks actually, there's a question around whether they might trigger more falls, and also around some bacteria or some infection control issues, whereas your goods shoes from home, not your slippers, I mean good shoes, ones that fit properly, are actually, evidence would show us, the best footwear to prevent falls. So in this situation, there is a better behaviour. To identify better behaviour, I'm giving an example around falls and falls prevention. Obviously, you'd need to go back to the literature, go back to the guidelines, the systematic reviews, to actually find the evidence around the particular problem that you're looking at. Bare feet are actually really good too, but that raises a different problem because nobody wants to be barefoot in hospital. It sort of could be a little bit icky. What does the new behaviour achieve? And this is really about patients' needs and expectations as well, because from our perspective as health professionals, we're focused on what we want to achieve. For this one, I think it's really important to focus on what's the actual outcome we want to achieve. Don't focus on the behaviour change of, that we want to stop people giving out non-slip socks. What we want to do is we want to prevent falls, right? So that's the outcome that we're looking at. So when we're talking about what the new behaviour wants to achieve, our patients' needs and expectations would be around not falling. That's not to say there wouldn't be patients coming in and going, where are my non-slip socks? I'm so used to getting non-slip socks, I expect them now. So there's an element of needing to explain to the patients around, well, actually, what we know now is this. So what I'm going to do with you instead is, it could be tailored education, it could be a pamphlet that goes out before to patients to say, bring in some good shoes. I know we do that in rehab now. We ask patients to bring in their runners or their proper sensible shoes, not just their slippers, so that we can put into place falls prevention. Can we easily explain the new behaviour? So that's principle 3. There is nothing worse than having a really complex intervention that even we as clinicians can't explain, because you've got no chance then of explaining it to the patient. We need to understand why we're doing it. So in this situation, say for example of falls prevention, we want to be able to explain with the tailored education what we're doing. You don't want to have something complex like a robot coming in and doing something and you've got no way of explaining what the robot's doing or how it's being effective. So the new behaviour needs to be relatively easy to explain, or we need to have had enough training or information to feel confident in explaining it to our colleagues as well as to our patients. We need to make sure that the new behaviour, the substitute behaviour, takes about the same amount of time. Time is probably the most precious resource that health professionals have. And it's always the one that comes up time and time again. I don't have time to do this thing. So, if this new behaviour is going to take a really long time, does that mean we can give up another behaviour? How's it going to work? So we need to explore all these things with the substitute behaviour. If it's going to take an hour to deliver a tailored education program, that's not going to work. Because our numbers of people coming into surgery, etc., will be affected. So that's an example of a short form falls efficacy scale, which takes about, 1 minute to do, 1 or 2 minutes. So, that's a substitute for assessing for potential to fall in a healthcare setting. And that's one that's been recommended, I think, by the World Falls Organisation. And I love these short form scales. They're really important, particularly in acute settings where the throughput is really quick. And can we do the new behaviour? So will we have the skills? So in selecting the new behaviour, is it so wildly different that we're going to need a massive program to be able to learn it? Or is it in our current skill set, but just a slightly different way of doing things? So, ideally, we don't want to be tapping into something that's too new. It's okay to deliver some information on the new behaviour, but not necessarily an extensive program unless it's really warranted. And can we afford it? Will the substitute behaviour cost more? So, I don't know, non-slip socks versus giving out a pamphlet about reducing falls. It is important. We work in settings where, we do have restrictions around how things cost. So just finally, some clinical practicalities for us all to think about. Behaviour change, bringing in new practices, de-implementing all these different terms. I know I started off saying that it's not a solo sport, and I want to end with the same thing, saying that it's a team approach. And in a healthcare setting, it needs to involve everyone. It's the multi-disc team. It's your physios, your nurses, your exec, your managers, And it is important to involve your managers because we know that acceptability speaks to sustainable practice change. So we need to know that this new practice is acceptable to exec and management as it is to the clinician, because otherwise it's not going to stick. Won't last beyond the pilot period. The quality improvement team, we have to work with quality improvement. They're fantastic. They're a great resource and they're very good with local change. And of course, patients and families and carers, they're central to everything, and they're an important part of behaviour change for all those reasons that we discussed before. That's it. Thank you.